very warm Sunday morning to each one of us. Welcome to another exciting webinar on Myelodysplastic syndrome by Mumbai Hematology Group. I'm Dr. Manoj, and it's my honor and privilege to welcome each one of you on behalf of Intas. And this has been possible because of our program director. We all know him very well, Professor Dr. M.B. Agarwal sir. A warm welcome to you. Sir is Professor and Head Department of Hematology at Bombay Hospital and also Consultant Hematology at Leelavati and Brij Candy Hospital, an institution, an inspiration, a teachers of teachers, multiple awards and accolades to Dr. Professor M.B. Agarwal sir's credit. Thank you for making it so enriching every Saturday and Sunday morning, sir. A warm welcome to our chief guest today, Professor P.K. Sasidharan sir. And also our guest speaker today, Dr. Austin. All our discussions, you have been making it really lively every day. Last but not the least, all the delegates who are joining from 14-15 countries every Saturday and Sunday, thank you for making it. May I request Professor Dr. M.B. Agarwal sir to take it forward from here.
Thank you, Dr. Manoj. Good morning to one and all. So today we are discussing myelodysplastic syndrome, and the lecture will be delivered by Dr. Austin Kulasekhararaj from London, UK. This webinar is brought to you by Mumbai Hematology Group, supported by Intas and managed by Mice Ideas. I thank Dr. Manoj Kumar and his team from Intas, Mr. Rajesh Sharma and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our chief guest of the day, Professor P.K. Sasidharan from Calicut, our guest speaker, Dr. Austin Kulasekhararaj from London, all our discussants who are themselves eminent hematologists, and you participants for sparing your Sunday morning. Coming Saturday, 7 p.m., we have discussion on diffuse large B-cell lymphoma. How do you manage it in 2022 by Dr. Cami Maddox from Ohio, USA. And the next Sunday, we have Dr. Farooq Wandru from London speaking to us on myeloma in 2022, what has changed. To introduce the discussants today, we have some wonderful people. Dr. Pravas Mishra from New Delhi, Dr. Prashant Bhatt from Mangaluru, Dr. Shinto Francis Dekaden from Kozhikode, Dr. Priyanka Samal from Bhubaneswar, Dr. Ragesh Radhakrishnan Nair from Calicut, Dr. Vivek Agarwala from Kolkata, Dr. Deepesh Lad from Chandigarh, Dr. Ketan Nathani from Mumbai. It's time to introduce our guest speaker, rather our chief guest, I'm sorry. And we are privileged today to have presence of Professor P.K. Sasidharan. It's my pleasure to introduce my friend and colleague, Professor P.K. Sasidharan, this morning. He's Professor of Medicine, former Head, Department of Medicine and Division of Hematology, Government Medical College, Kozhikode. He's former Chairman, PG, Board of Studies, Kerala University of Health Sciences. His PhD, Research Guide, University of Calicut. His former President, API, Kerala Chapter. Former Scientific Advisory Committee member, National Institute of Immunohematology, Mumbai. Former Dean, Faculty of Medicine, University of Calicut. He did his MBBS from Calicut Medical College, and he was awarded the Best Outgoing Student Award. Did his MD, General Medicine from PGI, Chandigarh, and he was one of its noted alumni. He's published 95 papers, including the landmark studies on vitamin D deficiency and SLE. He also developed new criteria to diagnose SLE, what is called the Cozy criteria. He had been the examiner for National Board of Examinations, PGI Chandigarh, JIPMER, Pondicherry, Kerala University of Health Sciences, Nizam Institute, Rajiv Gandhi University, KMC, Manipal, Bombay University, and West Bengal Medical University. He's authored Doctor's Pocket Companion, Guide to Clinical Practice in Post-COVID World, Healthy India, and chapters in many textbooks of medicine, clinical medicine, and hematology. The recipient of many awards and fellowships. His postgraduate teaching experience of 35 years. We are privileged today that he has spared his time and is going to address us and inaugurate this event today. Over to him.
A very good morning to all. I thank Mumbai Hematology Group and Dr. Agarwal for the kind invitation. I thought I'd share some of my thoughts on hematology. Clinical hematology is really fascinating. But to make sure that our fascination benefits the society, we need to make sure that. Otherwise, there is no meaning in that fascination. Our fascination for hematology or any other branch of medicine is genuinely beneficial only if we take some effort to prevent the diseases that we encounter and manage. It's always management of diseases, not just treatment, because when we manage diseases, we will be taking care of the situation arising from the illness too. Our fascination will benefit the society only when we are capable of working up and solving diagnostic issues and management issues as well. Incidentally, only I got involved in hematology because I was fortunate to work under Professor K.S. Salim for almost 8 years, from 1987 to 1995. Professor Salim was a consultant in hematology in UK, and on coming back to India, he preferred the job in internal medicine rather than exclusive hematology work. He continued to work after hematology and internal medicine together, look after hematology and internal medicine together, till he retired from Calicut. I still consider that kind of model as great, to have one specialty and internal medicine together, or one specialty and even family practice together to be maximally useful to society. And also, that model will preserve and nurture our clinical skills, because clinical skill is a tool that we use for practicing medicine. The PGI Chandigarh, where I did my MD too, has that sort of arrangement in hematology, nephrology, gastro, and endocrinology departments. They still look after internal medicine and that specialty together. When Professor K.S. Salim retired from Calicut in 1995, it was only natural that I had to continue looking after the hematology section for almost 20 years, till I retired in 2015. And after retirement from the medical college, I continued to look after that same kind of work, but only do clinical hematology or cold hematology problems, along with looking after other clinical problems without any bias towards any particular organ system. But I do not manage problems like leukemias and lymphoma these days. Even while doing heavy volume hematology work, I'm proud to say that multitasking had been my way of life. I enjoyed multitasking. I'm happy that I was responsible for several of my students getting attracted into hematology, but countless numbers of my PG students became general physicians with interest in competence in clinical hematology. This was possible only because of the unique arrangement that we had at our medical college, looking after hematology and internal medicine together. To avoid missing the unique opportunity at Calicut, combining medicine and hematology together, I even did not give proposals to start DM hematology. I gave proposal for starting DNB, but unfortunately, the MCI took out DNB from the medical colleges by then. Still, I could manage to organize an exclusive hematology facility at our institution, a 40-bedded ward for hematology, which serves primarily for the marginalized sections of the society. I am sure the junior residents trained under me are doing good clinical work, even while they continue to practice as general practitioner or general physicians. Some of my students got fascinated in hematology and gone into exclusive specialization in that branch. But I do not wish them to be known as super specialists, because they also should not feel that they are super, because there is nothing super in medicine. We become super only by saving lives of our patients. But the expenses needed for saving each patient and the total numbers of patients saved together would measure the relevance of our genuineness of our work. I consider most super feeling in a doctor's mind should be the number of satisfied smiles we get expressing their gratitude or the thank you smiles on the patient's face. Whether you are multitasking or working solely in hematology, there are a few important points the young aspirants and trainees should take care of. For that matter, anyone who wants to specialize in any area of clinical work. Doctors should strive to achieve maximum clinical skill before focusing on narrow specialties, especially so in India. Because in India, when the patients have the freedom to consult you without being referred by competent GPs, unfortunately, India only is encouraging this kind of doctor shopping. In some countries, the hematologist comes into a picture only after a complete diagnosis. For that reason, they could even afford to be poorer in clinical diagnosis and clinical skill. But clinical skill is a combination of several skills. And that is a trademark of any good doctor, whether you are a hematologist or a generalist. Hematology needs maximum clinical skill, especially so in India, as you get diagnostic problems too. I still keep getting large numbers of undiagnosed anemias and cytopenias even now. Besides, there are several other multi-system diseases like SLE with hematological problems which could be dominating in the clinical presentation. Therefore, clinical skills should be maximally fine-tuned in the hematologists as well, not only in the GPs and family doctors. But the truth is that only those who are good at clinical skill will make good hematologists. It is mandatory to acquire clinical skill before you take up hematology as a branch. That's what my advice to the youngsters trying to pursue hematology. Please never believe that diagnosis would come through computer printouts or with imagings. That I can give numerous examples of that. I have with me patients who were confidently diagnosed as MDS, but even with the positive genetic test, they were advised bone marrow transplant. But unfortunately, the doctors who evaluated missed beetle deficiency. There were telltale evidence of the skin manifestations of beetle deficiency, and the patient on inquiry did not consume meat at all. That simple history was enough. It was unfortunate that beetle levels were normal in such patients. This happens very often to the tune of about 40% in patients with beetle deficiency. So do not depend on laboratory alone. Other examples which I remember are non-Hodgkin's lymphoma diagnosed by histopathology and immunohistochemistry turned out to be SLE. Another one, pleural fluid cytology diagnosed as malignant pleural effusion was simple tuberculosis. It was a sampling error. Another was pulmonary infarction with pleural effusion diagnosed wrongly as adenocarcinoma. It was IPLA syndrome with pulmonary thromboembolism. Now, another point I noticed is several patients are diagnosing polycythemia rubra vera because of unnecessary upfront investigation with the JAK2 mutation. Many of them have simple secondary polycythemias due to weight gain only. Please remember that every symptom or sign has multiple contributing factors. These factors vary from patient to patient. Clinical skill is essential to identify all of them to make our treatment truly patient-centered. Some of the named syndromes like Castleman disease, Rosae-Dorfman, Kikuchi, these are not diagnosed in themselves. They are just histopathological curiosities described by observant pathologists. The causes of them we need to identify by evaluating the patients. Even an evident or clear bone marrow suppression that could be occurring while the patient is on chemotherapy may be happening in the background of several nutritional deficiencies like B12, folic acid, and vitamin D. Even protein deficiency is very common. Unless we identify and correct these deficiencies, the patient would never make a complete recovery. Several refractory anemias are due to multiple problems. There's no point getting one diagnosed by some test. It usually is the tip of an iceberg only. overlap between autoimmune disorders and malignancy, overlap between nutritional disorders and hematologic problems, overlap between infections and metabolic problems, all are very common in clinical practice. There's no algorithm-based diagnostic workup, no protocol-based treatment for any patient. These algorithms and protocols are only a rough plan or a guideline for the beginners, and we need to know how to individualize or make it tailor-made to the situation. It also means we need to study the patient before applying that protocol, and therefore we need to individualize and modify. All these need tremendous clinical skill. In short, the mindset of an astute clinician is essential to make a good hematologist. Good hematologist should also be good internist. Only a good internist can become good hematologist too. Those in other branches wanting to become hematologists should necessarily undergo some intensive training in general medicine before they take hematology as a specialty. It's very difficult for a pathologist to become a good clinical hematologist unless they undergo some intensive training to grasp all the tricks of history taking and physical examination. I have mentioned several such issues in the new book which I published recently, The Guide to Clinical Practice in Post-COVID World. Before I conclude, let me say one more point, that we should know an unpleasant truth, that India now has the highest disease burden in the world, despite being very rich. Despite being the richest nation in the world, USA too has a similar problem. The poorer people must depend on charity and philanthropy, both in these two countries, USA and India. By following the footsteps of USA, we too have created a similar but even worse model with more serious situation than USA here, because of the poor focus on social security and human development. Philanthropy has a great market in these two countries, that is India and USA. You get enough opportunities for winning awards and medals here. We keep forgetting the fact that health cannot be achieved in compartments, either in a body or in a single society, region or religion or a community alone. We have forgotten to provide social determinants of health and have forgotten to build a base for modern medicine, that is, as in other countries, which obviously is made of family doctors. We are the only country without a base for modern medicine, that is built by family doctors. We have to do something on that too. One more truth every doctor should know is the most fascinating for genuine multitaskers is to work as a GP or family doctor. The government and the doctors in India do not realize that. You can be a hematologist too while working or practicing as a GP or family doctor. Already we have too many unscientific practices which are being popularized with the blessings of the governments due to our false beliefs and sentiments rooted on the so-called rich tradition of which we are falsely taking pride. Please know that using such sentiments only, Ayush and unscientific systems are being promoted in the huge vacuum created by missing of family doctors in India. It's that vacuum which they make use of. I'm sorry if I mentioned some points which are not usually discussed in academic meetings. I wish all the best, and let me congratulate Dr. Agarwal for his untiring efforts to educate students across India in clinical hematology. Thank you for inviting me once again. Thank you. Thank you so much.
Thank you, Dr. Sasidharan, for sparing your time, inaugurating our webinar and giving the words of wisdom. We'll now move on to the second part of our this morning session, and that is starts with Sunday quiz. As you know, we'll be putting a quiz to you, and you'll be sending your reply to this email ID, that is mbagarwal1@gmail.com. And that's your quiz. A 42-year-old man with metastatic lung adenocarcinoma presented with disease progression on PET scan. This was after 15 months of a stable disease on Pembro. Molecular testing revealed EML4-ALK fusion, and the patient was started on the ALK inhibitor alectinib. Prior to alectinib therapy, his hemoglobin was around 13.3 to 14. 3 months after starting alectinib, his hemoglobin dropped to 9.5. His peripheral blood smear revealed marked alterations in the RBC morphology. And here is one of the film that you see showing some RBC changes. We'll keep this film on because that is what you're supposed to answer. And I'll be soon putting the question to you. And that's another film of the same patient. The question to you is, what is the most likely etiology of his anemia and the associated RBC changes observed in the peripheral blood film? And we're going to give you some options and you have to choose which is the correct option. So on the right side, you once again see the blood film, and on the left side, you have been given 8 options, one of which is correct, and just the number of that option, 1, 2, or whatever, is to be emailed. So the options are, these are incidental genetic RBC membrane disorder changes. This is acquired thalassemia. This is anemia of chronic disease, in this case, cancer. This is secondary autoimmune hemolytic anemia. This is drug-induced hemolytic anemia. This is malignancy-induced microangiopathic hemolytic anemia. This is malignancy-induced low-grade DIC. And lastly, this is marrow metastasis with secondary myelofibrosis producing changes in the RBC morphology. So one of these 8 options is the number of that, 4, 5, 6, 7, 1, 2, whatever, is to be emailed. We have a case for you, but as we have run out of time, I think I'm going to skip this so that we do not encroach on our main job of the day, which is the lecture this morning. And it's now my private privilege to introduce our guest speaker of the day. You've heard him before at more than one occasion during these webinars, and we are privileged once again to have his participation as a guest speaker this morning, and that is Dr. Austin Kulasekhararaj from London, UK. He's consultant hematology at the prestigious King's College Hospital, London. He's honorary senior clinical lecturer at King's College, London. His clinical interests are in the field of myelodysplastic syndrome, aplastic anemia, PNH, other marrow failure syndromes, and myeloid malignancies. He leads the King's National PNH Service. He's passionate about delivery of clinical trials. He's current national coordinating investigator for many phase 1, 2, 3 trials. Current drive is to bring novel therapies in the field of aplastic anemia, PNH, TP53 mutated myeloid neoplasias, and to improve the platelets. Translational research work, Bloodwise Foundation, British Society of Hematology Senior Clinical Research Fellow, molecular immunological pathogenesis of MDS and aplastic anemia with particular focus on overlap disorders. He's scientific advisor for Patient Advocacy Group, MDS UK, and member of the MDS NCRN Working Group. He's member of the European Society for Blood and Marrow Transplantation, Severe Aplastic Anemia Working Party. He's authored or co-authored over 100 articles in peer-reviewed journals and has contributed book chapters in major textbooks. Well, it's my privilege to invite him to deliver his lecture this morning. Over to you, Dr. Kulasekhararaj.
Good morning, Professor Agarwal. Thank you for those kind words and introduction as well. It's always a pleasure to be with the team there, and hope I will be able to do some justice to the talk. I'm assuming you can see my screen and hear me okay?
Yes.
Okay, great. Okay, so I think it's great to be back here again, and to talk on a slightly different topic. And as Professor Agarwal has mentioned, I've spoken on aplastic anemia and PNH, but predominantly my research and PhD was in P53 mutated MDS, and my clinical practice also mirrors that. So, and I think it was fascinating to hear the Professor Sasidharan talk about how clinical hematology is so important. And I'm so privileged because I totally understand that we need to be extremely strong in clinical medicine before you go into hematology, because it still remains a fascinating specialty. And if we translate to patient benefit, that is the major thing. So I'm just going to go over a few newer developments, but also keep some of the things very basic for people who might be just into the field of myelodysplastic syndrome. So what is this MDS? And I'll take into three parts around diagnosis, prognosis, and therapeutic aspects of myelodysplastic syndrome. So one of the prerequisites as per WHO 2016 classification for MDS is presence of persistent cytopenia, at least in one lineage, although very rarely we see cases of patients with MDS who do not have significant degree of cytopenia. So we all know that the first thing we look at is the blood film morphology. And the first thing, as we heard in the first session, was we always want to see if there is any secondary cause and correct the secondary cause as well. And if the secondary causes are treated, but if the cytopenias persist despite correction of secondary causes, then we need to see if the patient fit for invasive investigations. And as Professor Sasidharan indicated, we still see in this day and age as well that number of patients are misdiagnosed as myelodysplastic syndrome due to various underlying reasons. So this was a chap we saw nearly 5-6 years back, very standard new onset anemia with macrocytosis, a few symptoms of tiredness, nothing much in the past history, and he was taking quite a few multivitamins and supplements. So because of the persistent macrocytic anemia, but with the normal clinical examination and screening of these blood results, this patient was referred to a hematology practice in a local hospital, and this patient was found to have trilineage dysplasia with ring sideroblasts of around 6% and also had some vacillation, but he had normal karyotype and normal myeloid gene panel. Interestingly, when he was referred to us, we went through a detailed history and noted that he was on extremely high levels of zinc supplements for many years. And when we did the blood assessment for copper levels, he was found to have extremely low copper levels. So lo and behold, we stopped the zinc. He had improvement in his anemia and disappearance of dysplastic features. So I think a word of caution at the beginning itself is dysplasia has got differential diagnosis, and please be aware of number of mimics, imitators, copycats, and other things as well before giving a patient a diagnosis of myelodysplastic syndrome, because this has got significant connotations, because this is essentially a pre-leukemic disorder or malignancy, so you need to be careful before giving that diagnosis. So first word of caution is not all dysplasia is myelodysplastic syndrome. So once you've ruled out secondary causes, then you see, is the patient fit for invasive investigation? Sorry, apologies for bringing a 91-year-old into this discussion here, because it might not be, this is a patient in UK who I looked after for many years. So this lady had an isolated macrocytic anemia and was transfusion dependent. And at that age, she was quite reluctantly said, I don't want to do a bone marrow aspirate, which was extremely right. And we did a peripheral blood myeloid gene panel and found that she had an SF3B1 with a variant allele frequency of 30%. So the question here is, does this patient have diagnosis of MDS? You might say probably yes, but if you want to be a purist, as per the WHO criteria, WHO doesn't define any subtype of MDS just based on peripheral blood features and genetic features, other than finding a DELF-IQ or an SF3B1 in the context of having ring sideroblasts of 5 to 15%. So this patient did not have a bone marrow. So you cannot say that this patient has got myelodysplastic syndrome. So this patient did not at that time have a bone marrow, so we left her in a category of not yet diagnosed to have MDS. And for other patients, if a patient is fit, we would always want to do a bone marrow and look for morphological assessment, including dysplasia, blasts, and iron stain. And we know that there is a minimal morphological criteria for MDS, and then you classify them as per the WHO 2016 classification. So what happened to this patient? So she had persistent macrocytic anemia, so she did not respond to erythropoietin stimulating agents plus GCSF. And because she was symptomatic of anemia and was transfusion dependent, she agreed for a bone marrow aspirate under the auspices for a clinical trial, which we had at that time. So she had a bone marrow aspirate, and the bone marrow aspirate showed that, yes, she did have ring sideroblasts of around 40%, and the bone marrow was consistent with this phenotype, so it fitted in with the picture. But it did not end there, because this trial was only for patients with refractory anemia of the ring sideroblasts, transfusion dependent, but and we know with the morphological criteria, which is extremely important to look, but it's also important to make sure that this is not due to other coexisting features like was indicated before, underlying autoimmunity and other things. But we need to be careful about the morphological features of dysplasia, as some of it is illustrated there. And we all know that dysplasia should be present in more than 10% of the bone marrow aspirate, and dysmegakaryopoiesis as well. But there was some discussion going on about maybe increasing the threshold of dysmegakaryopoiesis, and we'll always correlate these findings with the trophine biopsy. So we have morphological criteria for diagnosis of MDS, but if a patient does not have morphological criteria for MDS, what value would we have for the cytogenetic analysis? And that is where we have these category of presumptive evidence of myelodysplastic syndrome, as indicated there. But please note, some of the common abnormalities seen in MDS, like trisomy 8 or del20q, does not come into this presumptive evidence of MDS, although chromosome 5, 7, and 17 abnormalities do come here as well. So is there an underlying cytogenetic abnormality which will help to classify this diagnosis? So coming back to our patient, so we all thought that this patient had MDS with ring sideroblasts, but when the cytogenetics came back, which usually takes a week or 10 days to come back, the bone marrow cytogenetics showed isolated del5q. So the question is, where would you put this patient into a classification? Obviously, she was not included in the trial because she had del5q, but it's not surprising, because even if you look at the data, 15% of patients have a coexisting del5q and a ring sideroblastic anemia as well with SF3B1 mutation. So it can be seen, although it is rare. So we know that we link genotype to phenotype, or maybe the other way around, I should say, phenotype to genotype, because of some classical features which we see in del5q MDS, or a Pelger abnormality in the context of deletion 17q, 17p, or SF3B mutation in ring sideroblastic anemia, and also the context of del20q, because interestingly, del20q MDS usually do not have significant morphological dysplasia, because they do have some subtle dysplastic changes, and they're associated with U2AF and the link between monocytosis and certain mutations like SRSF2. So where did we land up with the diagnostic classification of MDS? It started nearly 100 years back with D. Guglielmo, who's described other conditions as well, and then refractory anemia, pre-leukemias, to number of other classifications. Initially started when it was quite simple, and I still like this very simplistic classification of dysmyelopoietic syndromes of EB and CMML. And as time goes on, the number of categories keeps going up, as per the 1982, 2001 to 10 categories, and 2008 to 11 MDS categories. And we all know with the WHO 2016, we have different categories of MDS. And the few changes are every diagnosis of MDS, depending upon, irrespective of the subtype, starts with the word MDS, and then goes as ring sideroblast with single lineage or multi-lineage and EB1 or EB2 based upon the blast cell percentage either in the peripheral blood or in the bone marrow blast. And we've always known that MDS is not a single entity with a spectrum of changes seen in MDS. And I know we are now into the era of talking about these 4-letter acronyms like ICUS, IDUS, CCUS, which I'll come to in a minute, but I still like the historical terminology of what used to be called by Professor Alan Jacobs, saying it's not yet or not quite MDS. That's what this NY and NQ stands for, saying that you've not got MDS yet or not there yet. And we also know that the overlap of diseases with MDS, and some people say MDS sits in the shadowlands between a cancer and a non-cancer, but also in the context of proliferative diseases and also marrow failure. And you can see this appearance in a patient where you can have empty areas of the bone marrow associated with cellular areas as well. So once you have a presumptive cytogenetic category, then that will help in the classification and the diagnosis and prognosis as well. But what if you do not have any morphological criteria for MDS and no cytogenetic abnormality? You would continue to clinically monitor them, but also potentially do genomic myeloid gene panel or genomic analysis as well. And that is where the categorization of between an idiopathic cytopenia of unknown significance, where you do not have any cytogenetic or genomic abnormalities, but do have cytopenia, but with no MDS changes, compared to a cytopenia with clonal cytopenia of unknown significance, where you detect a mutation. And there are certain mutations which has got some positive predictive value for a later diagnosis of a myeloid neoplasm. So some of the examples are you need to have 2 or more mutations, presence of a spliceosome mutation, or co-occurrence of these DNMT3A or ASXL mutations, not just on its own, but co-occurrence, and also a variant allele frequency of more than 10% gives a positive predictive value that this patient has got a higher risk of going into MDS down the line. And another simplistic way of putting it is, if you have aging normal blood count and mutations, this is called the CHIP, or ARCH, or age-related clonal hematopoiesis or clonal hematopoiesis. And this is seen more in the older individuals, people with previous cancers, people with previous therapy for other solid cancers have a higher risk. But if you have cytopenia with no mutations, minimal dysplasia, then you call it ICUS or IDUS. Cytopenia with mutations, no dysplasia is CCUS, and we all know dysplasia plus or minus mutations is MDS. But the important thing is about the negative predictive value, because cytopenia without mutations usually means that they do not have an underlying myeloid predisposition at that stage or likely down the line. But we all know it is a spectrum of changes rather than just a one-off change in there. So patients can evolve from one spectrum to the other. Just a few things on the current development, because this is a patient we had seen in the last, I would say 6 to 7 years, a chap in his 60s, presented with Sweet syndrome, which is acute neutrophilic dermatosis, weight. He had a fluctuant low-level IgM paraprotein, but he also had 2 thrombosis, he had orbitomyositis, and also had an underlying diagnosis of MDS within inverted commas, and he also had a severe COVID-19 related pneumonia. And at the same time, we also saw this chap who was 55, who also had a histiocytic sweets, weight loss. He had lung infiltration and also a few other adverse reactions to anakinra as well. So we were sort of scratching our heads, because initially we put these two patients into a category of Sweet syndrome associated with MDS. But the question was, is there a unifying diagnosis for these 2 presentations, 2 cases who presented like this in their 50s and 60s, weight loss, fevers, skin rashes, and we were also able to find some vacuoles in the bone marrow. And is this a late onset autoinflammatory disease? And in December 2020, this paper came out showing that there are cases of somatic mutations of this gene called UBA1, which induces severe adult onset autoinflammatory disease. And as a hematologist, some of the characteristic features are seen indicated here in the sense they have vacillation not only in the erythroid progenitors, but also in the myeloid precursors as well, with significant systemic autoinflammatory disease. And it's an X-linked and it's an acquired somatic acquired mutation in one of these E1 ubiquitin activating enzymes. So it's interesting to say that this is a diagnosis which has always been around, but we've not been able to pick it up until this description. And currently, I have 6 cases under our care with this VEXAS syndrome as well, some of them are responding very well to azacitidine. So just in the diagnostic section, I want to put this in because this is quite a new development, interesting thing, and we don't know how many we would have seen, but we would have missed it because we did not understand this phenomenon, although we know every practicing hematologist would have seen these kind of cases during their clinical practice. The other thing I want to touch upon in this diagnostic section is the germline predisposition. Yeah, some of the conventional teaching which I've been taught when I was in training was, if you come across a patient who is 40, 50, or 60, do not think there is a germline predisposition for MDS AML because that's highly uncommon or unlikely. But this dictum has been totally changed because you can present with disorders with germline predisposition to MDS and AML, even at the age of 60s and 70s and 80s, and very much depicted with this DDX41, which I'll expand in the next few minutes. So again, comes into the WHO, which has brought in this classification with germline predisposition and some of the clinical features which you need to be careful about. So about personal history of cancers, family history of cancers. So do not take age alone as a factor to say that this patient has or doesn't have a germline predisposition. And we did a large series with the Japanese colleagues and a few other colleagues looking at this germline mutation of this DDX41. And you could see the mean age of onset of MDS AML is 62, not in the tens and not in the pediatric age group. So again, showing that there are these genetic conditions which can have long latency. This is an autosomal dominant condition with second hit mutations happening as well. And essentially to show that if you look at a large cohort of MDS AML patients, nearly about 4% of those patients will have an underlying constitutional DDX41 mutation, because this has got implications not only for therapeutics, but also transplant considerations and also for counseling of other family members as well. So if I switch my gears in the next 10 minutes to prognosis of MDS, where have we come from the prognostic understanding of MDS? So we all know that the old IPSS is indicated there, 800 odd patients. This is the stratification of the hemoglobin, neutrophils, and platelets. Very simple karyotypic classification with most patients belonging to the category of normal karyotype and predicting for overall survival and leukemic-free survival. And we knew that the new cytogenetic classification from Julius Sands nearly 10 years back was the backbone for designing the IPSS-R prognostic classification. So you could see that these cases are divided into 5 different categories, going from intermediate good to very good, or intermediate to poor and very poor, with different median overall survival. And as you all know, this was incorporated into the revised IPSS, a big step change with a large number of patients, 7,000 odd patients, And quite classically, 80% of patients were more than the age of 60 years. And the few changes were there was substratification of this bone marrow blasts with less than 2% and 2 to 4%. We all know, as some of the morphologists here, that how difficult that is to delineate and how statistically significant it can be between different people. But the few things was the depth of the cytopenia was included, which is very important because we all know a patient with a platelet count of 40 will behave differently to a patient with a platelet count of 98 and with different median overall survival. And this was some of the reasons, because there was a high weightage given to blast percentage in the initial IPSS, while cytogenetics was not given that much weightage, but that was changed over in 2012. And with the advent of mutation testing in MDS, I know, unfortunately, we cannot get away from this in the era of molecular development in the field of hematology, but also in MDS, because historically, we were only seeing a few genetic abnormalities in the context of MDS, but they were not very specific to MDS because we see it in other cancers and other disorders as well. But with the advent of next generation sequencing and other sequencing techniques, we know that close to 90 to 95% of MDS patients will have a molecular genomic abnormality in them. And we know that some of the genes which are associated in a higher proportion. And not only that, but they have prognostic significance as well. This is just one slide showing the value of P53 mutations, not only in poor risk cytogenetics, where it delineates this group of patients, but also in isolated Delphi Q. But there are a number of publications similar to that, bringing in the impact of it. So I just want to stress the molecular working groups molecular classification, which was presented in ASH of 2021 by Elsa Bernard, looking at how much value do genomic abnormalities add to the IPSS-R classification. Again, this was a very large effort from 24 centers, 3,000 odd patients with a median age of 72, and patients with less than 20% blast and white count less than 13 were included. Few things which is important compared to IPSS-R and IPSS-R. Therapy-related MDS was included, constituted 8%, and patients on disease-modifying agents were included in this classification because, if you remember, IPSS-R did not include patients who were on disease-modifying therapies. So they looked at conventional cytogenetics and targeted sequencing of 152 genes, and the variant allele frequency was around 2%, more than 2%. And if you look at it, which is what I showed you before, 94% of patients had one genetic mutation, while 6% of patients were negative. And if you can look at it, median number of lesions were 4 per patient. Neutrophils did not come into the prognostic model, and cytogenetics, individual karyotype did not come in, but the IPSS-R cytogenetic group came in, and mutations were either present or absent, and few genes, these genes were included in the mutation model. Number of mutations was important, but not the variant allele frequency or gene-to-gene interaction. So they looked at leukemia-free survival, overall free survival, and AML transformation, adjusted for age, sex, and MDS subtype. And these were the 3 main mutations which came up, which had significant prognostic implication, but the frequency was low for, obviously, for MLL, PTD, and FLT3, but P53 was there in 7% and SF3B. And they come up with this model of indicating a patient, where would they lie? So an average patient would have a score of 0, and 1 point increase will double the risk, and 1 point decrease will halve the risk, both for leukemia-free survival and AML progression as well. Again, this is a few things we can use in the model. And one of the main things was, because historically we were all said that 70% of MDS patients are low risk and 30% are high risk MDS, but this potentially helps to re-stratify patients and predominantly upstaging rather than downstaging these patients. And this was validated in an independent cohort. So essentially, it's personalized, reproducible, and interpretable. And they have the web calculator. I think some of the preliminary web calculator is online if you want to go and see it on the website as well. So again, indicating that these are things we can see. Sorry, just okay. So what are the, now switching gear to therapeutic options in the next 20 minutes or so. So we know that MDS, people have said that why do you do clinically MDS? Because it's quite depressing, because you do not have significant therapeutic options for MDS patients, and you need to be an eternal optimist to treat MDS patients because these patients do not do well. But things are slowly getting better from the therapeutic perspective, and which we'll touch upon. So these are some of the FDA and EMA approved therapies, and probably 2020, 2021, quite a lot of developments with approval of few agents and some breakthrough designation therapies as well. But obviously we know in UK, there are not many approved therapies as of now, and obviously we will talk about what is there. So how do you manage a low risk MDS? When I mean low risk, it's low intermediate IPSS or very low intermediate IPSSR. So I still say that even for low risk MDS, transplant should be discussed after diagnosis. With non-transplant things, supportive care. We know that there was a good study done about the hemoglobin threshold by Professor Simon Stanworth, looking at liberal versus restrictive strategy. And not surprisingly, patients who had a liberal strategy of transfusions did better. And because we know we always have individualized hemoglobin thresholds, but we need to look at patient by patient as well. GCSF in cases with recurrent infections in combination with EPO, or to facilitate delivery of azacitidine. I'm not going to touch upon the role of TPO receptor agonists, but we use regularly tranexamic acid. And chelation we've always considered in patients who had high transfusion burden for a long period or high ferritin. And we use the Exshade or Deferasirox, although licensed only a second line in UK. So how would you treat them in the context of EPO? So this is a very old, 20-year-old Nordic algorithm of using serum EPO and transfusion requirement with predictive scores. I still use it, and it's quite handy. We use either Eprex or darbepoetin or neuracomin for 8 weeks, double the dose for another 8 weeks, and add in GCSF for the next 8 weeks. So would use it for a period of 6 months before saying has it worked or not worked. There are a number of other newer classifications for predicting response to EPO over and above the Nordic score, which is one of them is the Canadian score, the ITACA score, and the IPSSR as well. So there are slight improvements from the Nordic score, but I still continue to use the Nordic score rather than the newest scoring system, but you might find benefit in using other scoring system. And this is quite fascinating as well, because the question is, when do you start erythropoietin? Would you start before the, at the time of symptomatic anemia, before they become transfusion dependent, or before they have a low hemoglobin, at the hemoglobin above 100? And this is looking at a practice in Europe, looking at various strategies, like patients were treated. Some of them were treated with EPO before the onset of anemia or before the onset of transfusions. Some were treated at the time of anemia. So variable practice. But the main thing is, if you start EPO prior to your first transfusion, the duration of response seems to be longer. And if you start EPO at the time of untransfused state but symptomatic anemia, these patients do better compared to patients who are transfusion dependent and started on erythropoietin. So what else drugs do we have? So obviously we have lenalidomide in the context of del(5q)-MDS. This is based on a number of trials looking at erythroid response. So in the context of MDS with del(5q), 60 to 70% of patients will show transfusion response. Nearly half the patients will show cytogenetic response, and the duration of response will last for around 2 to 2.5 years. What about in the context of non-del(5q)-MDS? So this is the data, nearly 5 years old, looking at lenalidomide in non-del(5q)-MDS, showing that 30% of patients can have transfusion independency for a period of 8 weeks. So this is the data from Alan List, published recently in JCO, looking at the role of lenalidomide plus EPO in non-del(5q)-MDS, not showing a significant response in this group of patients when you add EPO along with lenalidomide. So in del(5q)-MDS, we do have some role, or in del(5q)-MDS, lenalidomide is used, but not in non-del(5q)-MDS. It doesn't have significant response other than a group of 20% of patients who might show transfusion independency for 24 weeks. I would say transplant should still be considered mainly for patients who are heavily transfusion dependent, who lack clinical trials, severe cytopenia, fibrosis, rapid progression, and lack of standard therapies as well. What about agents like luspatercept, the newer agents, which are activin receptor ligand traps and work on the late stage of erythropoiesis by blocking GDF11 and thereby promoting SMAD pathway. So these are agents which are given subcutaneously every 3 weekly. And as you would have seen that this trial data published now a couple of years back, use of luspatercept in patients with ring sideroblasts, showing that the 37% of patients had response of 8-week duration of transfusion independence. But if you look at blocks of 8 weeks, nearly half the patients had at least 8-week periods of transfusion independency. And this drug has now been trialed in patients with in patients with MDS, both ring sideroblasts and without ring sideroblasts, in comparison with EPO and best supportive care. And this is the COMMANDS trial, which is ongoing. Few other agents which have shown some promise and awaiting phase 3 data is this drug called Imtelstat, which is a telomerase inhibitor, which binds to the RNA template of the telomerase and helps in downstream pathway. So again, showing in a phase 2 data, nearly 37% response rate in the overall cohort, but a higher transfusion independency in patients who've not had previous lenalidomide. So again, the phase 3 data from Geron is completed, and we'll look forward to the results, hopefully by end of this year or next year. And sometimes people use azacitidine in low-risk MDS. Is there a role for it in the context of low-risk MDS? Doesn't seem to be a significant benefit, although low-dose AZA is used in US and other countries in this setting as well. So again, showing that AZA plus EPO in patients who are refractory to EPO has not been shown to be much beneficial as well. Oral azacitidine, so this is the data which was published in JCO, looking at patients who were transfusion dependent, but also thrombocytopenic with a placebo trial, which is 300 milligram once a day for 3 weeks or 21 days compared with placebo. And that shows that, again, 30% transfusion independency and for either 2 months or 3 months, showing a better response than placebo. But unfortunately, there were more deaths in the AZA-03 arm or the oral AZA arm, but that could be because of a significantly low neutrophil count at baseline, but there was no difference in the median overall survival. This is a very good, fascinating agent. This is an oral decitabine with a drug called cediziridine, which is a cytidine deaminase inhibitor, because we all know that liver and gut makes a lot of these hypomethylating agents ineffective due to this production of these enzymes, which is why you cannot use it orally. But if you use it in combination with a cytidine deaminase inhibitor, you will be able to overcome that and be able to deliver the hypomethylation, so which is being studied in this ascertain study. So this is another drug which is going through phase 2 data, which is a HIF1 alpha inhibitor or prolyl hydroxylase inhibitor, which is being shown very good data in the context of renal anemia. So this drug called roxadustat has also shown very good benefit in the phase 2 data in low transfusion dependent murder patients. So this is an algorithm taken from ASH educational booklet a couple of years back, predominantly US-based algorithm, and looking at how they would treat, including patients with isolated thrombocytopenia, where they can use off-label thrombopoietin agonists like L-trombopag and romiplostin, and they're able to use drugs like azacitidine in the context of even low-risk MDS as well. And there are some studies published from the US groups as well. So I think there are a few options which are there for low-risk MDS treatment options which are going through trials, but I think definitely better than a couple of years back when we did not have any significant options. A few points is there are loads of things we learned from COVID, but one of the things I thought I'll put here is the role of repurposed drugs, because we know we used a number of repurposed drugs and ability to design innovative platform trials. And in UK, we are just using this trial, which is ongoing at the moment, of comparing 2 different arms in patients with transfusion-dependent low-risk MDS based on some biological rationale, but predominantly to use repurposed drugs to see whether we can improve hematological response. I think in the last 5 minutes, I'll take what do we have in the context of high-risk MDS, because predominantly we know high-risk MDS starts with transplant or no transplant, and we would always want to consider a patient with their transplant eligible, or do they have a donor, and also look at see if they have other comorbidities which would make them ineligible for a transplantation. So these are the questions we always ask ourselves in the context of high-risk MDS. So how do we approach it? And we know in the context of patients who are transplant eligible, there is still some discussion about what would you do pre-transplant? Would you induce them? Would you use hypomethylating agents? Would you use chemotherapy? Or how would you do? And what do you do for a patient who's got 5 to 10% blast? Do they need induction chemotherapy, or would you decide on an individual basis? So I think these data, obviously there is no randomized controlled trial, but conventionally higher proportion of blasts and hypercellular marrow, we would always induce these patients with chemotherapy, or maybe in the current era, we might use CPX351 or Vyxeos, or we might consider hypomethylating agents as well. So the 5 to 10% is a bit of a borderline category, whether do you need induction chemotherapy or not. Quite a few centers take them directly to transplant, but if you have hypocellularity or fibrosis, you need to be careful about. But non-transplant treatment, not eligible. Very rarely we use intensive chemotherapy, but predominantly azacitidine based upon the AZA-001 trial as indicated there, with a median overall survival of 24 months. But as we all know, trial data is not the same as real life data, because we know it's not the 24 months. This is a large series of with the median overall survival of 17 rather than 24 months. And here it's only around 11 months. And patients who fail azacitidine and long-term responses and long-term survival are less than 5%. And this is an important thing to note, because azacitidine is a very good drug, but patients do not have long-term responses. And sometimes we struggle out to keep these patients on hypomethylating agents. But obviously, I always say keep them on as long as you can, because sometimes the best response can come later. The type of response does not influence the overall survival as well. And also, we know that there is therapeutic options are very limited if these patients fail hypomethylating agents. And we know number of patients do not tolerate azacitidine. And we know that there are primary and secondary failure, and patients who fail azacitidine do not have significant overall survival, with a 2-year survival of 15%. And there are some favorable risk factors. And this is shown in this data looking at outcomes after azacitidine or decitabine failure. So we know that if you fail HMA, there are few options, and we know that transplant and other investigational agents or intensive chemotherapy has got possible better chance of controlling the disease and giving a better median overall survival. But what we tend to do is we always look for to see at the time of HMA resistance, we see for, are they eligible for a transplant? Are there any targetable or actionable mutations? Are they eligible for a clinical trials? And we'll come up to the venetoclax combination in a minute, but important to continue other measures as well. So what are the new agents which are there in the context of MDS, high-risk MDS treatment? I probably know that you probably are using venetoclax with azacitidine in high-risk myelodysplastic syndrome patients in MDS, but the phase 3 data is not yet out, although it is used quite commonly because you have a better overall response rate in patients who are HMA naive if they're treated with hypomethylating agents and venetoclax, similar to the AML data, but we need to wait for the phase 3 data, which is the Verona trial, which is ongoing, to see what it would be. Few other agents which unfortunately haven't been turned out to be as promising as the phase 2 data showed. So this was a drug which many people were looking forward to, a drug called eprinatopopt, which reactivates mutant p53 and restores the wild type configuration of p53. Is a drug given IV, which was used in combination with azacitidine. And the phase 2 data was extremely fascinating, with overall response up to 80-90%, which we do not see in the p53. But we know the duration of CR was short as well. But unfortunately, the phase 3 data did not meet its primary endpoint, with the CR rate seen of 33% compared to 22% with azacitidine alone. So unfortunately, this is not a drug which was as promising as it turned out to be in the initial phases. Other drug is a magrolimab, which is a checkpoint inhibitor targeting CD47. So this is going through a number of phase 2 and phase 3 clinical trials in the context of MDS, similarly to AML as well. And these are some of the programs with anti-TIM3, which is sabatolimab, which is also going through a number of phase 2 and phase 3 trials as well. So there are a few agents like the anti-TIM3 sabatolimab, or magrolimab, which is the checkpoint inhibitor, and the TIM3 checkpoint inhibition as well. This drug, again, was promising quite a lot at an initial phase called Myelodysplastic, which was targeting the NEDylating enzymes. But unfortunately, again, the phase 3 study did not meet its primary endpoint, which was presented in ASH last year as well. This is an ongoing trial, which I talked about earlier on, of oral cytobin or ASTIC-727, which is a combination of oral decitabine with cytidine deaminase inhibitor called cediseridine. So this trial is ongoing in the context of intermediate and high-risk MDS as well, and there is a trial in low-risk MDS as well, so oral hypomethylation, and we look forward to the trial. So there are a number of agents which are there, which are ongoing. So unfortunately, we know in the context of historical doublet therapy in the context of high-risk MDS, i.e., when I mean doublet, azacitidine plus something, have failed miserably in phase 3 trial. But currently, do you think that azacitidine and venetoclax is the standard of care? I think it's probably used in a number of countries, but I think it's still premature because we need to wait for the phase 3 data. And it is the data currently is available is only in unfit AMLs, and we need to wait for the phase 3 data. There are a number of trials ongoing with venetoclax in combination with chemotherapy, and there is also a number of trials with triplet combination. But one thing people have always moved along in the context of azacitidine is, in the context of MDS and high-risk MDS and azacitidine, is people always think it's better to treat with combination agents, if available, either in clinical trials or approved, in an upfront setting, rather than allow patients to fail azacitidine and then try to rescue them. But the problem always becomes is when you try upfront setting with AZA and combination, if you fail that combination, then what do you do? So it is a difficult conundrum there. So we know that there were a number of phase 3 trials in MDS, high-risk MDS, which did not meet the primary endpoint. But the big question is, as you can see, most of them are treatment-naive things with venetoclax, magrolimab, or sabatolimab combination. We need to wait for these phase 3 trials to see whether they will buck the trend and give us more hope in the context of high-risk MDS. So these are some of the things we talked about in this 40-45 minutes. Again, we talked about number of diagnostic, prognostic things, but also therapeutic options, which are coming along slowly but surely in the context of both low risk and high risk MDS. I did not touch upon relapse or transplant much in detail, but that's another topic in itself, which needs to be addressed because of the high risk of relapse of MDS after transplant. So I think to conclude, I'll say we did talk quite a lot about incorporation of genomic and cytogenetic and molecular abnormalities, but I'd still say morphology still remains central and critical for diagnosis and prognosis and ruling out alternate diseases. Please be aware of germline predisposition. Don't exclude just because a patient is older, because these can manifest at an older age group as well. Transplant should be discussed and considered for every patient. We do have promising new agents. So the question is, the big question in MDS has always been, there has been significant advances in the pathobiology and the pathophysiology of the disease and understanding, but will we translate them into a therapeutic potential is the big question. So I think with that, I will stop and happy to discuss and take questions. Thank you.
Thank you so much, Dr. Austin, for that beautiful talk on all aspects of myelodysplastic syndrome, updating us and our colleagues. We have audience from almost 15 countries today who have logged in and who have listened to you, and the standard of care of MDS will definitely improve. We'll give you just a break for 2 minutes before we take up the question answer session, during which we will just answer the quiz that we had put for the students. So I'll just share my screen, answer their quiz, and come back to you for the Q&A session in 2 minutes. So going to this quiz that was put to you this morning, we told you about a 42-year-old man who has metastatic lung adenocarcinoma, which had progressed on Pembro. He had this molecular lesion for which he was then put on alectinib, which is an ALK inhibitor, and his hemoglobin dropped. And the peripheral smear showed certain changes, and these changes were shown to you in these 2 slides. And you were asked about the etiology of anemia, together with the changes that were seen in the red cells, and you were given these 8 options. Interestingly, we have received answers for all 8 of them by a variable number of those who have participated. And many have opted for many answers. So it was not that there was predominantly one particular answer that we got. So if you review the peripheral blood film, while the patient was on alectinib, what it shows you is spherocytes, it shows you acanthocytes, and it shows you cystocytes. These are marked here. You've got spherocytes, red arrow. You've got acanthocyte, the black arrow. And you've got fragmented RBCs, the green arrow. The other slide that was shown to you, same thing. The black arrow, you've got acanthocytes, you've got spherocytes with the red arrow, and you have got another acanthocyte here and few fragmented RBCs. Now, alectinib is an ALK inhibitor. It has been used to treat metastatic non-small cell lung cancer that have ALK mutations. In the phase 2 trial that led to its approval, it demonstrated that it improved the progression-free survival and reduced the risk of CNS lesions. Some of the adverse events associated with alectinib included anemia and increased bilirubin, and this suggested a potential off-target effect on the RBC membrane. Additionally, several recent case reports and retrospective reviews have described marked spheroacanthocytosis in almost 95% of patients receiving alectinib. Most of these patients had mild to moderate anemia, with some showing clinical or lab evidence of hemolysis. These red cell changes that we showed you are unique to alectinib, and they are not observed with other ALK inhibitors. One study showed that erythrocytes from patients treated with alectinib have reduced eosin 5 melanimide binding. And this may make some sense to you because that is what happens in hereditary spherocytosis. Interestingly, another study found that 6 weeks after cessation of alectinib, hemoglobin normalized, but the RBC morphology changes persisted. Recently, in British Journal of Hematology, from the French group of workers, this case has been published, acanthocytosis in an alectinib-treated patient. And that's the morphology of that case that is published in British Journal of Hematology. The issue is over here. There are a number of other earlier articles. This is also in British Journal of Hematology 2 years ago, 2 cases of marked RBC anisopoikilocytosis with hemolysis following alectinib. This is in Internal Medicine 2021, alectinib-induced immune hemolytic anemia in a case of lung adenocarcinoma. This one is Journal of Hematopathology 2021, case series of alectinib-related erythrocyte membrane changes. The last one over here is in Pathology 2021, alectinib-induced marked red cell spheroacanthocytosis. So in last 2 years, this has been published more than once. So the correct answer was, this is an ALK inhibitor, alectinib-induced spheroacanthocytosis. So the option that we're given to you, drug-induced hemolytic anemia, the one over here, number 5, is the best answer. So the answer expected was 5, and we got 9 people answering this. The second to the 9th are between 11:40 a.m. and 12:05 p.m. I'm sorry here. Dr. Sumit Mirg, Dr. Naved Tamboli, Dr. Yoga Lakshmi, Dr. Mayet Marlar Shu, Dr. Krishna Ratnam Kanan, Dr. Alpesh Kapadia, Dr. Vinod Sharma, and Dr. Christopher Lyon, exactly in this order. The winner is the fastest finger fast, and that is Dr. Gopinathan. You know Dr. Gopinathan, he has been our discussant at multiple meetings. He's a very brilliant student from SGPGI Lucknow, doing his DM clinical hematology. So congratulations, Dr. Gopinathan. His answer came at 11:49 a.m. And we will send you your prize in a week's time. So I stop here, and now we take up the question answer session. So those who are present here, please, I request you to open your videos. Meanwhile, I'll put up some question from the audience. Dr. Sumit Mirg has a question. Young patient with 17% bone marrow blast, NPM1 mutated, but hypocellular marrow, has a matched sibling. 3+7 versus ESA when or upfront HSCT. What will be your option?
Yeah, I think it's an interesting question because it's a bit slightly semantics as well. Some of the purists say that NPM1 mutation itself means that this is AML rather than high-risk MDS, because in the context of pure MDS, to have an NPM1 mutation is quite low, less than 2%. So some people even say that should be similar to the co-binding factors, should we say that presence of NPM1 mutation itself should make it AML rather than MDS. Then if you come to therapeutic options for NPM1 related myeloid disease, I'm sort of phrasing my word as not MDS or not AML. I think there is very good, because it's a good disease in the sense like prognostically, because whatever you do, the response would be higher. So conventionally, we've been using chemotherapy for these kind of conditions before consider them for transplant. But in UK, what we do for these cases is we monitor their NPM1 MRD. So if their peripheral blood NPM1 transcripts after 2 cycles of chemotherapy or after azacitidine venetoclax shows that it has gone into a negativity on the peripheral blood, we tend to monitor these group of patients over a long period of time, because the chance of relapse is around 20%. While if the NPM1 MRD is positive, the chance of relapse is close to 80%, and then we'll consider other treatments, including a transplant. I think few caveats here is you're saying it's an young patient. How long would you monitor these group of patients? What's the risk of late relapses and other things? But I would still, in the context of an NPM1 mutation, I would still have possibility of monitoring them closely rather than taking them for an upfront allogeneic transplant. I'm assuming the karyotype is normal.
Okay, just one part of it you mentioned aza-ven or 7+3. So with the outcome 7+3 being so good, will you ever try aza-ven for a young person?
I probably will, because there is no comparative data between AZA and VEN, and 7+3 are unlikely to be any comparative data in the future as well. So it is a difficult one. Although you could technically argue, if you have a hypocellular marrow to begin with, would you consider them for a transplant? Would you consider them for a chemotherapy, because the chance of recovery and regeneration might be affected? Although the counter argument is, why would I be worried? Because I've got a sibling donor lined up. I could transplant them if they do not recover their hemopoiesis. So it's a difficult one, and I think it's individual choices how a system works and how a physician and the patient is comfortable in that setting, because there is no published data, and I don't think that there will be published data in these scenarios as well.
But aza-ven will never be curative, right?
No, I don't think so. It will be curative. Although saying that, we have a number of patients who have maintained their NPM1 MRD status for a long period of time following induction chemotherapy, not aza-ven. We don't have enough mature data in that setting.
Thank you. Till I see any raised hand sign from the friends present here, I will continue with the audience question. Sumit has another question. Data on aza plus ven response in patients who have failed aza and who have lost response to aza. So after aza failure, what happens? Aza plus.
Yeah. So there are two trials which are ongoing in that setting. One was presented by Amazeden in last ASH, looking at what response rate would you get in the context of exactly what he said, failure of azacitidine, and then adding in azacitidine to that. So the response rate, overall response rate in that setting is around 37%, including CR, PR, and also hematological improvement as well. So there is a group of patients who will respond to after failing of azacitidine, but never use monotherapy of venetoclax after failing azacitidine, because the data for the monotherapy arm is extremely poor, because there is only 7 to 10% response in the monotherapy. So there is definitely a role for adding in venetoclax to azacitidine upon failure of azacitidine in that context.
Just one question about the dose of ven. Is it like a fixed dose 400 for everybody, or you titrate the dose as per tolerance? Do you go up? Do you go to the lower dose in long term? What do you do with the dose?
Okay, so this is a fascinating thing, because all the studies have been with venetoclax ramp up going from 100 to 200 to 400, and then keeping them on 400 milligram for 21 days out of 28. And some of the trials have gone down to 14 days out of 28 in the context of MDS as well. In UK, what we tend to use is 100 milligram venetoclax along with posaconazole. So posaconazole 300 milligram, because there is some good studies to say that the venetoclax drug level achieved is 100 milligram is equivalent to 400 milligram in the context of using it with posaconazole. So at least you get a cheaper for less drug cost if you're using 400 milligram in the context of using it with posaconazole. There is no data to say how long would you use venetoclax and at what dose, and that's all maturing out from the Verona trial and also from the Viali A trial of using this as well. But in MDS, as compared to AML, If people are using venetoclax, you need to be extremely careful. You cannot give the 28-day cycle at all. There will be significant dose delays and dose interruptions and dose modifications as well. So I'm more comfortable, at least for the first cycle, of using either 14 or 21 days in UK, obviously off trial setting. Yeah, because it's not approved.
Thank you. Dr. Ketan, your question.
Good morning. Good morning, sir. Thank you for the wonderful lecture. So my question is, so like in a 70-year-old patient, where with the pancytopenia on peripheral smear, and the bone marrow reported is markedly hypocellular. Because of this scant cellularity, the cell's morphology is not commented upon. So, are there any other like clinical criteria or any morphological criteria by which we can differentiate between hypoplastic MDS and aplastic anemia?
Yeah, so that's an important question as well. And we have published this data in leukemia about 3-4 years back, I think. So where we are trying to differentiate between hypoplastic MDS and aplastic anemia. So some of the morphological features, as you clearly said, is obviously we need to look for, in the Trifine, need to look for abnormal localization of immature precursors, CD34 staining, any fibrosis, or any specific markers for megakaryocytes to see if they are hypocellular or hypolobated and dysplastic. So, and then this is probably where you might find some value in cytogenetics and genomics as well. So we came up with a scoring called histological and genomic scoring score, where it doesn't matter what you put them under a category, but if they do not have those morphological features, do not have any cytogenetic or genomic changes, they behave more like an immune-mediated bone marrow failure rather than as an MDS. So if the scoring is higher, either histological or genomic, they behave more like a conventional MDS, and then you treat them accordingly as per your algorithm, whether you're treating bone marrow failure or MDS.
Okay, thank you so much.
Thank you, Dr. Ketan. I received one question by email about sabatolimab. You mentioned this, just a passing reference. Wants to know more about it because this drug is going to be marketed by Novartis in India soon.
Yeah, so it is, again, it's a drug which is, as I mentioned by passing because it's not approved, it's only in clinical trials. It's an anti-TIM3 antibody, which is a checkpoint inhibitor. It seems to have very good phase 1 and phase 2 data in the context of MDS and also in AML. AML, it seems to be a bit more advanced rather than in MDS. So there are a number of clinical trials which are ongoing, and these are all called stimulus clinical programs, both in MDS and in AML as well, in combination with azacitidine. So there is a pivotal trial which is sabatolimab in combination with azacitidine compared with azacitidine alone, which is a phase 3 trial, and that will tell us whether this drug has got added value to azacitidine in a randomized controlled fashion. But the one word of caution obviously is when you're using checkpoint inhibition, either TIM3 or PD-L1 or PD-1, you need to be extremely careful about the CRS and other things, and the setup needs to be there to monitor these group of patients for the particular complications these patients get during this. But as I said, and as I put in a couple of slides, these are newer agents which are extremely going to be important, and to understand what the clinical trial data will show in phase 3, because as I said again in my penultimate slide, we've been bit too often in MDS world where the phase 2 data is extremely good, 70-80% response, and phase 3 invariably fails. So I'm a very optimist generally, but when it comes to this MDS clinical trials, I have a pinch of pessimism. So we need to look at the data before we come to conclusions.
Thank you. Dr. Vivek, your question.
Yeah, good morning, sir. A wonderful lecture by you. I mean, hardly any points where we would need clarification. But just one question around 5q deletion. So how do you approach to treat MDS with 5q deletion, and where do you place the role of lenalidomide in treatment of MDS as a whole, as well as in 5q deletion?
Yeah. So thank you for that question, and thanks for the compliment as well. So in the context of lenalidomide in del(5q), it's a very, very useful drug. We all know del(5q) MDS. I don't know about Indian data and literature, but at least in the Western world, del(5q) MDS is about 2 to 3%, not more, maybe up to 5%, not more than that. It's a very rare subtype of MDS. But I tend to use lenalidomide at an earlier stage, at the time of transfusion dependency. There was one trial published by the Spanish group looking at low-dose lenalidomide in transfusion-independent patients with del(5q) MDS, and I'm not sure whether we'll go that far. So yes, it's a very good drug in the context of del(5q) MDS, with close to 70% of patients achieving transfusion independence. We would start with a dose of 10 milligram, 21 days, and then continue it and assess for cytogenetic response in 3 months or 6 months. People who have achieved a complete cytogenetic response do extremely well, because I've got a patient who's been on it for 12 to 15 years. Yeah. And there was a very small data we published from us and the German group, and where we showed that in the context of del, which is important for countries like India, because we use lenalidomide for patients, and for 6 months, if they achieved a complete cytogenetic response and had a good hemoglobin, we even stopped the drug, and these patients remained in remission from hematological perspective and cytogenetic perspective for many, many years. And a few patients who relapsed responded to retreatment with lenalidomide as well. So I know this is a slight anecdote, but the published data is, yes, in patients with the deeper response, you are able to even withdraw the drug and maintain the response as well. And in the context of non-del(5q) MDS, I'm not a big fan. There is only a couple of studies published, as I showed you, and the one published in JCO by Professor Valeria Santini showed that around 20 to 25% of patients will achieve a response with lenalidomide in non-del(5q) setting as well. So it's worth trying if you don't have therapeutic option and the patient is able to do it. But I wouldn't try more than for three months or 6 months. If there is no response, there is no response, because people sometimes poorly tolerate lenalidomide. I know it's not the 25 milligram dose or myeloma, but still 5 to 10 milligram doses people tolerate poorly. We do not see significant thrombosis in the context of this dose as well, so we don't use thromboprophylaxis in that setting.
Okay, Dr. Vivek, thank you so much. Dr. Sumit has one more question. Azacitidine versus DLI for MRD positive disease post-transplant. How do you choose if there is no prior GVHD and full donor chimerism?
Yeah, so this is again a data poor territory. So again, I'm going to be very cautious, and I'm just going to say what we use. Yeah. So to answer your question, we use both. We use both in combination. So we use 2 cycles of azacitidine followed by DLI, and that always depends upon the chimerism as well. What the patient's chimerism is. If we do a fractionated chimerism in all of our patients post-transplantation. So if the CD3 chimerism is low, then there is a role for giving DLI along with azacitidine, but we tend to give DLI for patients who have relapsed MRD positive disease or relapsed post-transplantation, because we have a couple of studies going on of using DLI, because we use DLI prophylactively, we use DLI preemptively, and we also use DLI therapeutically, which is the question you asked, in the context with azacitidine. Because the problem is, we know that 30 to 40% of patients will relapse post-transplant with MDS. So MRD positive disease might transform into a morphological disease. So we tend to use azacitidine with DLI rather than each agent on its own in this particular setting, which you've indicated.
Thank you. Dr. Rahman has a question. How do you follow up a patient with bicytopenia with minimal dysplasia and no mutations?
Again, it's an interesting question as well. I think it's a question of I say if the bicytopenia is not significant, i.e. not transfusion dependent or not symptomatic of the bicytopenia, and if there is no morphological features of MDS and mutations are negative, I might probably even discharge this patient from the clinic because you're sort of making them more worried by keeping them in the clinic thinking that you've got something. So I know it might sound controversial, but I use these genetic panels in a slightly negative predictive value. So if you have somebody who sort of doesn't have morphological features, doesn't have MDS, doesn't have genomic abnormalities, you're at least reassured by the fact. Again, you can be a bit more semantic and say, oh, it depends on the panel you use. How many genes did you test? Did you test 5 genes or 30 genes or 60 genes? Or what was the VAF cutoff and all those things. But generally, if a patient is not symptomatic and you monitored the bicytopenia for a period of a few years and things are not getting worse and there is a reassurance, then I would probably reassure the patient and discharge.
Thank you. Yes, Dr. Vivek and Ketan, your hands are up. Any questions?
Yeah.
Yeah.
Sir, in the recent times, we have started using PARP inhibitors, olaparib, rucaparib, in a lot of maintenance setting, curative setting also in solid tumors, especially when they are BRCA BRCA mutant. And then one of the toxicities that we see long term is development of MDS and AML. So what is your approach to a case of PARP inhibitor induced MDS?
So thank you, Vivek. I'm totally out of my depth in that arena, I think so. So we don't use. So I can tell you a couple of examples. One is we did a very early phase 1 trial of using PARP inhibitors in the context of MDS, actually treatment of MDS, but that did not go too far. And then subsequently, I was part of one of those committees looking at the bone marrows of patients who are treated with PARP inhibitors to see whether they've got MDS as well. So it's a field where I don't think I've got enough expertise, and probably you guys see more cases in that context. We've not been referred that many patients on PARP inhibitors developing MDS, but that's something we have to be careful and look out for in the future. But that's something if you're seeing more cases, you need to put it out into the world for the people to be aware that this is a phenomenon which we see. It might be a handful of cases, but that's an important lesson, because that's the problem with all these targeted drugs and PARP inhibition. And like Professor Agarwal showed the case in the quiz as well, these are things which will come down the line of seeing these complications, which will never come up in a clinical trial. This is what we see in post-marketing and real life, and this needs to be put out to the world to know.
Thank you, Vivek. Dr. Ketan?
Sir, I wanted to know, like for any pathogenic or non-pathogenic mutations, how much VAF is significant? Like 3%, 4%, or is there any cutoff, or depending upon the clinical scenario, we have to decide?
Yeah, I think it all depends on the clinical scenario. The VAF cutoff, again, is a bit, so as you probably know, more than 2% is what is categorized into the CHIP and other things. Clinically significant, there is no data for it, because even the IPSS molecular, as I showed you, the VAF did not matter. Their cutoff was 2%. So the VAF of the mutation did not matter in the context of prognosis or significance. The one exception would be in P53, because if you have a VAF of 70 or 80%, then you know it's a homozygous P53 mutation and it's a biallelic hit rather than a monoallelic P53 hit, and they would have a poorer prognosis as well. In routine diagnostic laboratories like the laboratory which I part of at King's, we don't report variance less than 5% at all. We've established a cutoff of 5% and only report more than 5%.
Thank you, sir.
Thank you. So Dr. Priyanka Samal, she's here, but I think she has some internet problem. She has sent a question by email. How do we know from investigations whether TP53 mutation in a particular patient is monoallelic or biallelic? And second part of the question is, are monoallelic mutations higher risk than wild type TP53?
Okay, so I think some of the biallelic one I answered to the question earlier on. So with the conventional genetic panel, it's hard to say whether a mutation is monoallelic or biallelic other than by the VAF cutoff. Yeah. So if you have a high VAF of 70–80%, then you know that is a biallelic mutation. If you have a less than 50% or a 45%, then you only have a monoallelic hit as per the genetic panel. So to delineate that, either you need to do a FISH for chromosome 17 or a conventional metaphase cytogenetics. If you feel that the 17p arm is abnormal or deleted, then it is biallelic. If you have ability to do array CGH or SNP array karyotyping, then you can pick up the 17p deletion and also loss of heterozygosity of 17p by SNP array, not by array CGH. That will tell you that there is a biallelic hit. So just based on a mutation panel, you cannot delineate biallelic or monoallelic unless the mutation is homozygous or high variant allele frequency. The second question is, do monoallelic p53 mutations have a similar clinical sequelae or survival like a wild type p53? It seems to be the case in the context of the published data. So the one data which is published quite extensively in MDS is by Elsa Bernard, which was published in Nature Medicine last year. Looking at that specific context, and it seems to be monoallelic seems to do better like a wild type one, but obviously we need to have more data on that.
Thank you. She has another question. Young person, low risk MDS, isolated deletion 5q, responded to lenalidomide for 8 months, lost the response, and now the NGS panel shows TP53 mutation. No matched sibling donor available. Knowing that the overall survival is only 30 to 40%, even post-allo SCT, what will be your next plan of action? You would like to start HMA and then consider a mud allo transplant or a haplotransplant, or continue with HMA and wait for the transplant only when there is a second loss of response, especially if the blasts remain less than 15%.
Yeah, so I think it's a difficult one, because if you say as an young patient losing response to lenalidomide with a p53, I think it's very high risk for subsequent transformation to AML and high risk MDS as well. So I would be very conscious to the fact that this patient should go towards a transplant rather than try other things. You would probably want to have a short course of HMA and then take them to mud transplant, but not not leave them too long, I think so. And the one thing is, although p53, this is where I think it might be important to look at the p53 VAF status, because if it's a monoallelic, then you probably have a bit more time as well before planning the treatment schedule. But if it's biallelic, then the chance that it will go to AML is high. The other thing which I always worry about all these data in the p53 is they don't separate out del5q from other p53, because although p53 is a bad news in whatever disease, not just MDS, in the context of del5q, it seems to be slightly better than if you have a non-del5q or a complex karyotype high-risk MDS. So there are a few caveats, but I would still, for this patient, if they're losing lenalidomide with p53 mutation, I would suggest that those patients should be taken to transplant. Again, the caveat is people don't report the outcomes of del5q p53 MDS transplant, because p53 MDS transplants are put into one box and say they do extremely bad, but there will be subsets of del5q who might do better.
So if you have a del5q minus with TP53 mutation or complex karyotyping, to begin with, lenalidomide is a reasonable option?
And not with complex karyotype, but if you have a del5q with p53, still patients respond with hematological response. So what, say, for example, you have a 70-year-old who does not have a transplant as an option, and she's heavily transfusion dependent, but does have a P53, you would still treat them, because even with del P53 mutation, you would achieve a hematological response, but you might not achieve a complete cytogenetic response. But the patient will feel better and the quality of life, so that the patient is transfusion independent.
Right. One more question that has come, that if you're doing conventional karyotyping and you're doing NGS panel, is there a place for fish?
I probably would say no. If the conventional karyotyping, you're quite convinced that you have had the enough ISAN recommendation of 30 metaphases, the growth is good, and you use that laboratory quite often, you're confident with the laboratory, I probably don't think so fish is needed in that setting, because as you all know, the resolution for picking up a deletion or an abnormality by fish is also lower. It's less than the 20% threshold. So I think metaphase karyotype, if it is not failed, good 30 metaphases, good growth in a good laboratory would be more than sufficient rather than a fish.
Thank you. Another question is, when you are planning a transplant for MDS, do you do NGS panel for the sibling donor to look for germline mutations?
No. This direct answer is no, unless the patient themselves have got a germline mutation. Then we will do a predictive testing of a related donor to make sure they don't carry the germline defect before taking them to a transplant.
Okay. Some more questions in the question box. Dr. Arijit Nag has asked, what is your approach for treatment of hypocellular MDS? You've answered this, but he's put this question again.
Yeah, I think like what I answered before, I think if it's a hypocellular MDS and it's behaving more like aplastic anemia, like what I mentioned to Ketan, we would still treat them with, depending upon the age as well, we will treat them with immunosuppression with single agent cyclosporin to see if they have a response. But if they're behaving more like MDS with genomic abnormalities, and if they're high risk, then we would treat them with azacitidine.
Right. The triple ATG plus eltrambopac plus cyclosporin will be a preferred option.
But there is no data for the triple regimen in the context of hypocellular MDS, because people sometimes say, is it really an entity, hypocellular MDS, or is it a bit of a semantics? And WHO doesn't call hypocellular MDS as an entity. It does appear somewhere in the WHO book. So I think it's high time people need to put together the cases and come up with a consensus, because every meeting I go, I'm sort of bombarded with questions about hypocellular MDS. And I think some of the answers are not evidence-based. Some of it is practice-based rather than evidence-based. And I sometimes slightly loathe when I give those answers, because that's my personal perspective rather than published data. But technically we need to identify, before branding them as hypocellular MDS, make sure that this is not an immune-mediated bone marrow failure. Yeah. And sometimes people say it's semantics. If there is an immunological component, it doesn't matter what you call them. Is it AA or MDS? It doesn't matter. If it's immunological, if you have enough features to say there is an immune component, treat them as such and then worry later.
Sure. Dr. Arijit Nag has another question. If your patient is transplant ineligible, what is the advantage of doing targeted NGS, except probably deletion 5q?
I don't know. I probably will put it back to the questionnaire again, because you might pick up things like NPM1 mutation or an SF3B1, and then you might say, yeah, you got a better survival, you got SF3B1. If you have access to luspatercept, I might treat you with luspatercept. So it's mainly prognostication and also ability to identify targeted therapy, because you yourself asked about the NPM1 mutation in the previous case. So it is so those things help us as well. Sometimes when when you look at the mutation panel and say, why did I do it? Because it's made the matters more confusing rather than what it was in the clinical setup. So you do come across those, but there is value for it if you think of prognosis and targeted therapy.
Sure. Another question by him is, in a low risk MDS, if you have P53 mutation, what is your preferred treatment?
Yeah, so it's not uncommon in non-del(5q) low-risk MDS. So it's not common to have P53 mutations in low-risk MDS except del(5q) MDS. So I think it's very rare to find that. And even if you find that the VAF level will be very, very low, and we've got a few patients who have been monitoring, most likely there might be cases who have had previous cancers, that they would have had chemotherapy and other things, but manifesting as low risk as well. So that's something we need to look at. Yeah.
Okay. Post chemotherapy, when you develop MDS, is the behavior different?
Yeah, I think most of the post therapy related MDS AML patients behave more aggressively with complex karyotype, presence of P53 mutations, and quite aggressive cause, and also inability to respond to conventional treatments as well. So they do respond in a bit more aggressive manner. Although we do see sometimes post chemotherapy MDS patients behaving quite indolently as well. That's quite unusual, but can happen as well.
Thank you. Another question by him: in the low risk MDS, in your follow-up, what's your protocol for doing bone marrow examinations? And when you do this, do you also look at the molecular evolution?
Yeah, so historically, we used to do yearly bone marrows for our low risk MDS at all. Also, we've totally stopped doing that, because if there is no clinical change or no change in the blood counts in a low risk MDS, we continue to monitor them, and we don't repeat bone marrows regularly or sequentially. And again, we don't look at genetic panels at a sequential time point as well. Only if there is a change in the clinical status or blood counts, we would repeat a blood count. We'll repeat a bone marrow and a myeloid panel again. Right.
The next question by Dr. Tarek Ben is deletion 5q with RAEB1 or RAEB2. What's the role of lenalidomide?
Yeah, so there is one good published data from Leonelidis published in quite some years now, either in leukemia or blood, where there was use of lenalidomide in patients with excess blasts, provided it's isolated del(5q). If you have excess blasts and complex karyotype, there is no point in using lenalidomide in that setting. So you can use it if allowed in your country to use the lenalidomide in excess blast if there is isolated deletion 5q, and the response rates are quite good, up to 40 to 50% responses as well.
Dr. Shyam has a question. 46-year-old MDS with RUNX1 and SRSF2 mutation, 4 cycles of Ven plus Eza completed. Now, will you check for the molecular remission before going for transplant?
No, I don't think so. There is enough data to look at these mutations as an MRD marker. Yeah. So RUNX1 and SRSF2, as far as I know, will not disappear. And as Professor Agarwal said, Ven-Aza is not a curative treatment, and it will not take away the molecular abnormalities. So there is no data to suggest that we should be checking. Only in a research setting this has been done, but in a clinical setting, we don't have enough data to check for the presence of these mutations post chemotherapy or post Ven-Aza before transplant. And a link up to this question is, persistence of RUNX1 and SRSF2, will it have an impact on outcome? It might do, because why do patients with MDS relapse after transplant? Because we leave behind the genomic abnormalities and a few stem cells which are defective. That's why they relapse. But there is no way to say if you have a RUNX1 of 10%, that your risk of relapse is low versus RUNX1 of 50%, which is low. And the preference of a MUD versus haplo, it depends upon the center's experience and what availability you have. But definitely 46-year-old with an RUNX1 and SRSF2, I would consider transplant at some stage when you get good clinical response.
If you have a 9/10 mud, you'll go for that or haplo?
There is data. There is in MDS. There is some studies going on with comparing 9/10 with haplo, but I don't think so. It's mature enough to say what is better than every disease. This is the argument which is going on, whether you use 9/10 versus a haplo. And again, I would say these kind of things depends upon centers' experience and people, different countries as well, because if one is cheaper and has a relatively similar outcome, then I would go for that option rather than looking at trial data.
Right. There's a transplant-related question. I'm not sure whether we are transplanted or not. It's about conditioning regimens for allotransplant in MDS, for match sibling, for MERD, for haplo.
Yeah, so I do transplants as well, mainly for MDS and aplastic anemia, because we do it as a transplant and disease together, especially doing in the service. So although I don't claim to be an expert on it, but the regimens we use in UK for a matched sibling and unrelated donor would be flu, which would be 30 milligram per meter square for 5 days. Busulfan, we use variable doses, either BU2 or BU4, 2 doses or 4 doses. And the serotherapy we use is, in most of the UK transplant centers, is Campath based. So alemtuzumab, so we use 20 milligram per day and up to 60 milligram in related donors and up to 80 to 100 milligram in unrelated donors. Some of the related donors, we would use ATG conditioning as well. So essentially flu, BU2 or BU4, depending upon myeloablation or not, and Campath. In older individuals, we've been using flu trio as well, flu trio ATG as well. In haplo, we conventionally use just one. In a non-RIC haplo, we use the flu-cy TBI with post-transplant cyclophosphamide, like the Johns Hopkins Baltimore protocol with 2 grade TBI. There is a myeloablative haplo regimen, but we don't use that often because predominantly we go for MUD in that. Very rarely we use BU-cy, i.e. pure myeloablative conditioning in the context of transplant, unless we find very young patients with high risk disease as well.
Thank you. Dr. Chikodi wants to know whether micromegakaryocytes are specific to MDS.
No, not necessarily, is it? It's micromegakaryocytes are quite commonly seen in a few other conditions. CML is very, very commonly seen with hypolabated and micromegakaryocytes as well. Again, with delphi-Q, it's not pathognomonic, but micromegakaryocytes does indicate that there is this megakaryopoiesis if it achieves the right level as well. And yeah, so.
Dr. Arun wants to know, while the blast percentage we talk about for defining and classifying MDS, is it on morphology alone, or we can use immunohistochemistry, or we can use flow cytometry, especially if the marrow is hypoplastic or fibrotic? Yeah.
So as per the WHO, it is based upon the aspirate. I would yes, you're right. In the context of fibrosis and hypercellularity, you would want to use CD34 staining and CD11 staining on the trephine to corroborate your findings. Unfortunately, with the flow cytometry, CD34 is good, but we see in the context of number of situations where the 34 is negative and you're not able to count the actual blast percentage. I would still use morphology, but allied techniques like flow and immunohistochemistry do add up as well. And as you very, very much know, the context of NPM1 mutated, like the case which was discussed, you won't pick it up because they're all CD34 negative. So you might say they don't have excess of blasts at all. More so, that case was hypocellular as well. So you need to be very, very, very careful. If in doubt, there is a possibility of repeating the marrow aspirate, having somebody else double count the morphology as well. Because at the moment, we tend to double report morphological reports because there needs to be a concordance, some degree of concordance.
Dr. Radhika also wants to know whether there is a well-defined method of increasing the interval between when ESA cycles after a certain period, after how much period, how do you space them out, and how many cycles, etc.
Yeah, I think this comes up all the time, and there is no published data. But I would say practically what I tend to do, I don't, unless the patient has got any significant complications, I don't tend to space it out at least for a year. And once you reach a year time point, if they have a good response, a good hematological response, and the blast count has gone down and other things, I tend to go to, depending upon patient choice, I tend to go to every 6 weekly, or sometimes the patient says, oh, can I go 5 days? Then I do 5 days and keep it for weekly. I don't do both the dose duration and the weeks apart, because then you do one at a time and then slowly do it. And again, it's your gut feeling between you and the patient, and there won't be any published data for this kind. The only word of caution is high-risk MDS. When you stop azacitidine completely, the risk of relapse is extremely high, but spacing out is perfectly fine.
And the dose of ESA and when is untouched. It remains the same.
Again, we are waiting for the follow-up data on the VIALE A and C, and also the ongoing VIALE trials with venetoclax and azacitidine, because people, quite a lot of patients with AML, we have stopped the venetoclax. I don't know whether it's because of the funding issues or other things. We stopped the venetoclax after 6 months and kept them just on azacitidine. So the question is whether there is a beneficial just for keeping them on hypermethylating and take them off the venetoclax, but we will know. And similarly, as you very well know, with the Quasar AML trial of oral azacitidine maintenance, so is it behaving like that, or are we only giving maintenance therapy in the context of AML and MDS? Once you control the disease, then we can look at it. So again, that's all evolving data. We will get some knowledge down the line.
Dr. Roshni wants to know, in RARS, beyond luspatercept, what is the next best option?
No, I think in RARS, I don't think so. The good thing about RARS is, thankfully, it's a disease which can smolder around for a long period of time. So rather than trying to be very brave and giving number of different agents and making the quality of life poor, I would continue. If you don't have access to luspatercept, if they failed a good dose of erythropoietin with GCSF, I would continue on a transfusion support until you have newer therapeutic options available, because these diseases smolder around. Their risk of leukemia is also less than 10% of transformation. So these patients go on for a long period of time.
Thank you. Dr. Nilesh has a 47-year-old lady. She's MDS intermediate risk, going on for 5-6 years, but she's transfusion dependent. She received 6 cycles of decitabine. Post-therapy, the bone marrow is hypoplastic. She is transfusion dependent, not tolerating when, for your kind suggestions, how to go ahead.
Yeah, so I think the simplest answer, which I think you probably would know as well, would be because it's 47, transplant eligible, assume, would consider them for a transplant. But if they're hypoplastic, but with no excess of blasts and no cytogenetic or genomic changes, then the question is there a possibility of stopping the drug and think of other agents like modulating the immunomodulation type of thing with cyclosporin and other agents, or thrombopoietin mimetics type of thing, to improve their blood counts to see how it goes. But essentially for this patient, I would consider them for an allogeneic transplant.
Thank you. Dr. Sham wants to know, if one HMA fails, can you try another HMA?
Yeah, I think you guys have got more experience with using different HMAs, because decitabine is not approved in UK, but from clinical trial data, azacitidine, failure of azacitidine, decitabine, then you use decitabine, the response seems to be not that great. So we did a clinical trial nearly about 10 years back of using decitabine in AZA failure, 20 milligram per meter square for 5 days therapy, and there was not much response. But the published data from US of using azacitidine after decitabine failure seems to be slightly better rather than the other way around. And as you probably know, there were a number of trials with different hypomethylating agents like guadocytabine and other things. And unfortunately, they did not have significant effect and they've fallen by the wayside. Will it change with oral azacitidine and oral decitabine, the ASTX727? We don't know, but we are hoping that it will be different for this group of patients.
Thank you. The last question in the question box is about the pediatric MDS, if you want to answer. How does it differ?
I don't deal with pediatric patients, thankfully or not thankfully. But as you probably know, that most of these patients are, we need to be very careful about monosomy 7, GATA2, and also the SAMD9L as well, because there was a very good session in the recent meeting by Marcin Myelodysplastic differentiating those things. But essentially, most of the MDS in the pediatric setting is RCC. But if you have a monosomy 7, there is a 80% chance that they would have either a GATA2 or a SAMD9L. So those are the main things you need to look at. But I would hold my hands up and say I'm not a pediatrician, so asking the wrong person as well.
Okay. I have one question. When we say immune-mediated MDS, what is sine qua non to say this is immune-mediated?
Yeah, so this is sort of comes back to Professor Sasidharan and his initial introduction as well. This is an area I've been extremely fascinated and something I do a clinic with the rheumatologist once a month for these cases of MDS with underlying autoimmunity or autoinflammation. And like what he said, we have a number of patients who have concurrent diagnosis of an autoimmune disease. The question always is it chicken or an egg, or do they have both conditions, or one is due to the other condition as well. So when I say that, so as you know, my mentor, Professor Mufti, described autoimmunity in the context of MDS in 1978 or 80, I think. So when he did that, at that time, it was autoantibodies and immunoglobulins and paraproteins. So we did a large series looking at our group of patients with MDS and autoinflammation or autoimmunity with the Moffitt group, and found that about 30% of patients do have a concurrent autoimmune condition, whether as a coexistent diagnosis or as consistent along with MDS as well. And we struggle a lot because sometimes you have to treat the MDS to see how the autoinflammation received. Sometimes we treat the underlying rheumatological condition because they have more drugs than MDS physicians. So if you alter their immune profile, then we would do that. So we don't, it's mainly clinical based, which is why I'm waffling about giving you a right answer, because it's about seeing these patients and trying to be very strong clinically and understand and delineate these group of patients, because you don't want to give them two diagnoses. We always say it seems to be linked with the two conditions and we treat as we go along. So it is a very, very difficult balance when we see these patients. And a lot of misdiagnosed patients come with MDS and they have underlying lupus, underlying rheumatoid arthritis, or seronegative, or like what I told you about the VEXAS, this autoinflammatory syndrome as well, where they get these coexistent conditions and we have to treat them.
And in that situation, you will just follow the treatment of the rheumatological disorder and see whether marrow function improves?
Yeah, we do that. But in cases where we have things like Sweet syndrome or polychondritis, not diseases of autoimmunity, but because of autoinflammation, we have used azacitidine with very good success as well in dampening both the bone marrow dysfunction and also their underlying autoimmunity and autoinflammation as well. So we've used quite successfully azacitidine in that scenario with good benefit as well.
And what is your drug of choice for Sweet syndrome?
So sweets in the context of MDS, so we use azacitidine quite regularly. So we published our case series of 33 cases with Sweets and MDS in the British Journal of Hematology. It makes me think it's about 8 years now, and we are expanding our cohort. We've got now 50 odd patients, because interestingly, this clinic, which I was mentioning, we do it with the dermatologist as well. So myself and the dermatologist and the rheumatologist see these cases together, and they're referred from all over the country as well. So we do use azacitidine at a very early stage, because one of the earlier cases we saw, Sweets, was treated with 10 different immunomodulating agents and did not have a response, but he's doing well on the last 8 years on just azacitidine with very good control of Sweets as well. So we tend to use azacitidine.
Use colchicine?
No, not much, although sometimes we've been caught out with an underlying FMF as well. So we had a case who had a familial Mediterranean fever, because that's the spectrum of autoinflammation along with Sweets as well. So we had a chap who had FMF with skin lesions manifesting as Sweets, who responded very well to colchicine.
Well, thank you. Great talk and very long QA session. We were bombarded with, I think, almost 30 to 40 questions of different types, and you patiently answered all of them, made us quite grateful to you. And for the official vote of thanks, we have Dr. Manoj Kumar.
I think it was an amazing session, Dr. Agarwal and Dr. Austin. The whole interaction was so lively. And I also had to tell both of you that both of you were heard by 31 countries.
Oh, okay.
And I would like to thank them, those who were live logged in: Algeria, Australia, Bangladesh, Egypt, Ghana, India, Indonesia, Iraq, Malaysia, Moldova, Myanmar, Nepal, Oman, Pakistan, Philippines, and a small island called Cebu, island country, Sri Lanka, Sudan, UAE, US, Vietnam, Cambodia, France, Mauritius, New Zealand, Singapore, Thailand, UK, and Taiwan. Delegates from 31 countries had logged in today. So that's speaks volume about the level of interaction which we had today. Thank you so very much, Dr. Austin and Professor Agarwal, and also Professor P.K. Sasidharan for those pearls of wisdom, and discussants experts, Dr. Prabhash Mishra, Dr. Prashant Bhatt, Dr. Shinto Francis, Dr. Ragesh Radhakrishnan, Dr. Priyanka Samal, Dr. Vivek Agarwal, and Dr. Ketan Nathani. Thank you so very much for making this wonderful Sunday very, very, very useful. All of you have a wonderful Sunday, and I think I can't thank you enough for this wonderful, and thank you Mumbai Hematology Group for bringing this wonderful academic feast every Saturday and Sunday.
Thank you, Dr. Manoj and Dr. Austin. We will be troubling you for the 4th lecture.
Thank you.
30 countries was beyond my imagination. This is the highest we have had. Must be very, very odd hours for many of them. They are probably awake in the middle of night to listen to you. That's wonderful. Great.
Maybe make it 30. The person from UK was me, I think so. So make it 30.
Okay. Bye-bye.
Thanks. Bye.
Bye. Bye to everybody.
Bye.